Hello everyone, today we'll be discussing refeeding syndrome. Refeeding syndrome is defined as a medical complication that results from fluid and electrolyte shift as a result of aggressive nutritional rehabilitation. So metabolic disturbances as a result of refeeding syndrome manifest in cardiopulmonary, hematologic and neurological dysfunction in these types of patients. So, one of the hallmarks of refeeding syndrome is hypophosphatemia. However, there are other electrolyte irregularities which may include, but they are not limited to, decreased amount of magnesium, potassium, and thiamine. So, the major electrolyte imbalance we discussed, which is the hallmark of refeeding syndrome, is hypophosphatemia. However, of note is you may also take note of hypomagnesemia, hypokalemia, and low thiamine levels. So the causes of refeeding syndrome are multifactorial and they are linked to nutritional replenishment following a period of starvation. Accordingly, patients with poor nutrition who are rapidly or suddenly fed are at increased risk for refeeding syndrome. So, causes include eating disorders, chronic alcoholism, malabsorptive conditions like inflammatory bowel disease, chronic malnutrition, poorly controlled diabetes, oncological conditions, and postoperative state. So basically, when you look at all these conditions, what you'll take note is all these patients are at a risk of poor nutrition, and then once you start feeding them normal amounts of food or a balanced meal or maybe a higher calorie meal, so that can result into refeeding syndrome. So, refeeding syndrome diagnostic criteria they outlined as the following. So, there is noted decrease in serum phosphorus, potassium, and or magnesium level by 10 to 20%, which is mild refeeding syndrome, 20 to 30%, which is moderate refeeding syndrome, or more than 30% or organ dysfunction resulting from a decrease in any of these, and or due to thiamine deficiency, that is severe refeeding syndrome occurring within 5 days of reinitiating or substantially increasing energy provision. So, the exact pathophysiological mechanisms leading to refeeding syndrome have not yet been definitively clarified. However, the central aspect is the switch from a catabolic to an anabolic metabolism as a normal physiological reaction upon resumption of nutrition. So, of note is refeeding syndrome is a physiological response to the change in metabolic status. Catabolic stresses, processes such as fasting, stress reaction, inflammation, lead to a loss of intracellular ions, potassium, phosphate, and magnesium, sodium, and other micronutrients. So, the metabolic changes in a starved or malnourished patient after introduction of nutrition are mainly due to insulin stimulation following the availability of glucose. So when you look at this diagram here, we start from the top where you notice malnutrition. So what happens when there's malnutrition is you're not getting enough of glucose, right? So the body produces glucose using gluconeogenesis and protein catabolism. So when this happens is in the process of gluconeogenesis and protein catabolism, protein, minerals and vitamin depletion happens, right? Then, when you start with refeeding, the patient is malnourished, and then you start giving them normal feed or high calorie meals. So, they get carbohydrates as the main energy source. So, when we get carbohydrates in our body, that's increased levels of glucose, right? So, to balance that glucose, insulin is secreted. So, when there's secretion of insulin, what happens is there's uptake of glucose, but of note is there is also intracellular movement of potassium, magnesium, and phosphate as a result of insulin. Then, because glycolysis is taking place, so what will happen is there is increased utilization of thiamine. So, because of the above processes, what will happen is there will be hypokalemia, hypomagnesemia, hypophosphatemia, and thiamine deficiency. So the clinical features are mainly as a result of these same electrolyte imbalances. So hypophosphatemia will present with neurological symptoms such as paresthesia, weakness, delirium, disorientation, encephalopathy, a reflexive paralysis, seizures, coma, tetany. Then hypokalemia will result in features such as anteneurological paralysis, weakness, and cardiac. They can present with arrhythmias, contraction changes, and you can have respiratory failure. Under GI, they can present with nausea and vomiting. Hypomagnesemia, so neurological symptoms include weakness, tremors, muscle twitching, altered mental status, tetany, convulsions, seizures, coma, and they're cardiac, they can present with arrhythmias. Thiamine deficiency can present with encephalopathy, lactic acidosis, nystagmus, neuropathy, dementia, Wernicke syndrome, Korsakoff psychosis, wet and dry beriberi. Then sodium retention will present with fluid overload, pulmonary edema, cardiac decompensation. So what's the treatment or management of refeeding syndrome? So traditionally refeeding syndrome is evaluated by clinicians individually. So it depends on how the patient is presenting with what symptoms, because as you look at this, so there are multiple clinical features. So patient will present with certain clinical features that you need to target, okay? So that's how evaluation is individual. When enteral feeding is initiated after prolonged periods of being in a metabolically starved state. Recent recommendations on screening and surveillance of these patients focus on conserving calories and careful repletion of electrolytes. So your mainstay of treatment is you need to treat the symptoms as well as replace the electrolytes. So you correct the electrolyte imbalance. Differential diagnosis for refeeding syndrome is unique in the sense that it is a diagnosis of exclusion, requiring other more acute conditions to be ruled out. Fluid overload is one of them. Remember, we said there is sodium retention, which will lead to fluid overload, which causes a decrease in many of the electrolytes in plasma. This could lead to grossly depleted amounts of sodium, potassium, magnesium, or phosphorus. The after effects of refeeding syndrome must also be evaluated. So how do you prevent refeeding syndrome is if a patient with malnutrition or any other conditions we talked about earlier presents. How you commence them on a diet is maximum of 10 kilocalories per kg per day. And then if there is an extreme case such as BMI of less than 14 or negligible intake for more than 15 days, you start with 5 kilocalories per kg per day in extreme cases. Then feeding advancement is slowly to meet or exceed full need by 4 to 7 days. So complications of refeeding syndrome is electrolyte imbalance from refeeding syndrome can result in several complications. So as we had outlined in the table earlier, for the main electrolyte imbalances, potassium imbalances can lead to cardiac arrhythmias, QT prolongation, weakness, fatigue, paralysis, respiratory distress. Phosphorus can lead to cardiac arrhythmias, decreased 2,3-DPG production, decreased respiratory muscle function. Magnesium can lead to ataxia, vertigo, paresthesia, convulsions, depression, and QT prolongation. Thiamine deficiency can lead to cardiac dysfunction, Wernicke and Korsakoff syndrome. That's all about refeeding syndrome. If you like the video, please like, subscribe, and comment. Thank you.